Assalamu alaikum.
Walaikum assalam.
Long queue waiting for the. How many students are available now?
Already.
I can find that there is 26 only attendance. How many students in this batch?
24.
24?
24 students.
Oh, so all are available.
Yes.
Inshallah, we will at the end of the lecture we can get a video photographer together, inshallah. Okay, be ready for that. Let us start our lecture today by al-Kitab. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم Can you see my slides now?
Yes, Doctor.
Alhamdulillah. Okay. So today we are speaking about an important topic. I hear you. I hope you can react with me, please. I didn't prefer to speak in one direction. I will ask you many questions, and if you need any question, just you can get permission and ask, okay? Because our lecture today is about neonatal infection and sepsis, okay? It's very, very important and one of the top causes of neonatal death. How can, yeah. This is our study goal from this lecture, was to define what is the infection, okay, and what is the sepsis. How can we classify it according to many classification, either by age or by the causative organism or route of infection, clinical manifestation, how to diagnose, what is the differential diagnosis, okay, because sepsis looks like for other respiratory problem, for cardiovascular, for neurological, for airborne errors of metabolism, all of this can give you the same presentation, okay? Pathogenesis of septic shock are very important. Then how we can manage. Then we are speaking about some points about the health care associated infection, HAI. Do you know what is HAI? Raise your voice, please.
Hospital-acquired infection.
Yeah, healthcare associated infection. It means it came from us, either or a doctor or a nurse or whatever from the hospital situation. And this is by law is not allowed. Okay, but if we didn't do a good practice, we can infect many of patients. So healthcare associated infection are very, very important. Even in Islam, we are allowed only to give benefits. We are not allowed to cause harm. Okay, so let us start now. What is the neonatal sepsis? Neonatal sepsis is organism, mainly bacterial, but can be others also, came to the blood of the baby. Okay, if it came early in the first 2 days, 48 hours to maximum 72 hours, we are calling it early onset. Okay, if it came after 3 days, we call it a late onset. Okay, the most important thing for the neonate, which is the first 4 weeks of life, I mean it is from 0 to 28 days, the early diagnosis are very important. because late diagnosis of the sepsis, usually it will be accompanied by very high rate of morbidity and mortality. Am I clear? Here is the definition of neonatal sepsis. It is a clinical syndrome of systemic illness accompanied by bacteremia occurring in the first month of life, but late onset can be extended up to 3 months. Can you understand now? To say sepsemia, I mean the organism enter now inside the blood vessels and go to the central area. There is a lot of risk factor for this one, starting from the mother side. If she is carrier for GBS, if she have brom, if she has chorioamnionitis, which is the top one, healthcare associated infection, known as nosocomial infection, is the one of the important challenge now in practicing neonate or immune compromised patients. The healthcare is 100 times common than the congenital infection. NICU also has the highest rate than any other areas. At least 12% had one or more infection from the neonate. Many pathogens are developed, and if we are abusing the antibiotic, we will come to something known as MDRO, multi-drug resistant organism. What is the name? Multi-drug resistant organism. I mean, the organism can defend himself with the all antibiotic which we have, either first line, second line, third line, new antibiotics, still he can defend. And of course, if you cannot eradicate the organism, you will cause very high mortality. And even if the baby escaped, he will have a very high morbidity. The epidemiology, really, I found only in Malaysian, it is about 10 per 1,000, but this is 2007. In United States, it came to 12 per 1,000. Mortality, you can concentrate the mortality of an untreated sepsis can be as high as 50%. If the organism already in the blood and circulating, at least maybe 50% will die, and the remaining will get a very big number will get morbidity. Morbidity usually meningitis. Okay, there is difference in the susceptibility to infection between black infant have increased incidence of GBS and late onset. The risk factors, I think I need to make these photos small because you may not able to see. Can you, are you able to see me now or not? Hello?
Yes, we can see the slide.
Okay, that's good. So the neonatal sepsis, as we speak, it is a clinical syndrome, and it has a very high mortality and morbidity. It will affected by the age of the preterm, especially if the baby is extreme preterm, there is increased incidence of sepsis. There are relatively immune compromised at that time, okay, and a decreased passage of a maternal antibody. We will speak about that. So he is deprivated from two things. His immunity doesn't evolve. At the same time, suppose if he stay until the birth, suppose he will get immunity from the mother. So he is deprivated from both of them. The incidence of sepsis is slightly higher in the infant with a birth weight less than 1 kilo, which is about 26 to 28. Then in the infant after 1 kilo. So usually less than 1 kilo mortality and morbidity will be high. More than 1 kilo is better than that. The risk of death or meningitis from sepsis is higher in the very low birth weight. That's why we have low threshold to do lumbar puncture in neonate, especially if the inflammatory marker are high, to rule out that it include also meningitis. Sex difference, yes. Remember that the male are more susceptible, we don't know, than female. Really, male are not so lucky in the neonate. The mortality and the morbidity and the infection is more common between male. Even the survival rate or the girls in the ICU is higher. Durable gender. Okay. Now we can see this is the antibodies which come from the mother. You can see here, it will start from here. It will drop at the end of the first year. At that time, from the birth, baby will start to produce it. So there is the surge. It will come meet around 3 months. So the baby is covered at that time. Okay, if we give the baby vaccine also, it will be more, this is his own antibodies, it will be more. If without vaccine, it will be less. What happens if the baby doesn't get anything from his mother? He must rely on himself only for these 2 lines, which will get about 1 year to be more significant. That's why to prevent the premature delivery are very important, okay? And to prevent healthcare associated infection are very important. The neonatal infection can be divided by age. I mean, if it starts in the first 48 hours to 74 hours, it is early onset. After that, we can consider it as a late onset. If the problem came from the mother obstetric complication, it is also early. Okay, there is prematurity. It occurs frequently also for the early onset. The manifestation of early onset usually multi-system infection. I mean, by multi-system, the child with system started to have respiratory distress, and then so this is the respiratory. Then his blood pressure will start to low. This is the cardiovascular and the circulatory system failure. And then he may get convulsion. I mean, this is the CNS. He may get renal impairment, liver impairment. So it will be multi-system. The late onset sometimes bifocal or multi-system. If we speak about the pathogens, you must know the difference between the early onset and the late onset. The early onset, usually the microbe will be the GBS, which is the most common one, but still E. coli, Listeria, viruses, cons, which is coagulase, negative staph, sometimes sexually transmitted disease. We will speak about one of it in the end, inshallah, or fulminant course. All this, okay, if it is fulminant early onset, okay, like pneumonia or like that, it will carry mortality from 5 to 50% of the mortality. The late onset, usually the organism, cons will jump to be the most common one here. Here GBS, here is the cons. Staph aureus, E. coli, Klebsiella, Pseudomonas, Tyrobacter, Acinetobacter, GBS, and it is a slow course. So if you start early, it will be fulminant course with high mortality. If it occurs late, it will be slow course, usually with meningitis, up to 60% have mortality. But there is a lot of morbidity. So the early onset, as we speak, most probably it is group B, streptococcal, okay? And I didn't prefer group A beta hemolytic streptococci. I didn't prefer really to put abbreviation like GBS. If we said GBS, it can be Guillain-Barré syndrome. It can be a lot of things. So try to to handle a lot of abbreviation, please. So group B streptococci, known before as streptococcal agalactia. It is the most common organism associated with early onset. It is a gram-positive encapsulated bacteria, have many types. The most common is serotype, about 50%. It is colonized in the GIT and the genital tract, in infant sign of respiratory distress, cardiovascular instability, meningitis, shock, and death. The E. coli, as you know, it is a very famous gram-negative organism colonized in the maternal, urogenital, and the GIT. This is the second most common cause of neonatal sepsis in the very low birth weight neonate. Neonatal sepsis, it causes very bad meningitis, thrombocytopenia, and the death in the first day of life, maybe, if you didn't diagnose and intervene. That's why we will get the lesson after that. If you suspect the baby has sepsis and start to see some clue, don't wait until the full-blown picture, otherwise you are not able to save the baby. The listeria are very important. It is facultative anaerobe, gram-positive bacteria. About 17% of the pregnant women have a high risk for that. Spontaneous abortion still poses its side effect, but it can occur after that, after birth, by respiratory distress, sepsis, meningitis, granulomatous skin rash, a high risk of the mother consumed the milk. So we must ask if the mother have a raw milk or unpasteurized milk or even fresh meat. All this can increase listeriosis, and they will be accompanied by meconium aspiration syndrome in the preterm. The late onset, as we speak, the cons, okay, coagulase negative staph, okay, up to 50% of late onset of infection, especially in very low birth weight. Staph aureus is less, up to 8. Colonize the human skin. You must know that the human skin is the source of the infection. That's why cleaning our hand and like that, even our nose and the mouth are very important. Formation of biofilm protect the bacteria from the antibiotic. This is one character. These bugs is like every creature need to defend themselves. So they are able to do a biofilm to protect the bacteria from antibiotic penetration, and they help to evade immune system. MRSA, okay, methicillin resistant, it is about 28 of the staph infection in the preterm. Methicillin resistance, it means it will not respond to the simple antibiotic. You need to go up for vancomycin like that. But now there is also vancomycin resistant. If vancomycin, you don't know what to do. So you are just to do, and we cannot judge the result. The gram-negative organism like E. coli, Klebsiella, Pseudomonas, Enterobacter, Citrobacter, Serratia, all this, okay, responsible for up to 70% of death if she infected the small baby. You see how severe is it? Transmission from the hand of the healthcare worker, which is colonization in the GIT tract. Or unfortunately, sometimes they come for contamination of any IV fluid like the TBN. It is very, very, very dangerous. And I think they picked some outbreak and they found some of the medical stuff he doesn't use to wash his hand nicely after the toilet. Very, very dangerous. Pseudomonas has a very high mortality also. Citrobacter can cause brain abscess. You see how severe is the gram-negative? Very, very, very severe. Of course, this is the third leading cause of infection is the Candida. It's a risk factor for the very low birth weight, or if you are using a broad spectrum antibiotic for longer time. Okay, and if you didn't start feeding early, that's why even baby are very small, 500, we are trying to give him express the maternal milk, okay, EBM, even half centimeter, even 1 ml, it will prevent colonization by this organism. Of course, we have Candida and the non-Candida fungi. Okay, it carry high mortality and the neurodevelopmental delay because the fungus will do something known as fungal ball. The fungal ball will affect many areas. It can go to the heart, it can go to the CNS, and like that. So it is very, very, very dangerous. So please take care about that one. Are you with me?
Yes.
Yes.
I hope to feel that I am not speaking to myself. It is a very bad feeling. Okay, so if anyone needs to ask, don't worry. Okay, this is the Candida now. So now, again, just to let you remember the early onset sepsis, usually it will come through the mother. The most common one is the maternal GBS, colonization, or chorioamnitis, or BROM, premature rupture of membrane, or prolonged rupture. BROM in itself is a risk factor. If it is more than 18 hours, it is very highly risk factor. UTI, of course, multiple pregnancies, preterm deliveries, all this can lead to early risk, early neonatal sepsis. The late one, it occurred because of breakage of the natural barrier, which is the skin and the mucosa. Remember that if the neonate came to us, even if it's 400, 500, you need to break the skin for vein, you need to break the UVC and the UEC, you need to intubate the baby, you need to check the blood gas, you need to put a lot of like pulse oximeter, ECG lead, temperature probe, a lot of things which can traumatize the skin. So lead for that. Even if you put catheter for longer time, it will affect also. Invasive procedure like ET tube, all this can cause necrotizing enterocolitis. If you use antibiotic for long time, it will defend itself. Even some said the H2 receptor like omeprazole and like that can increase proton pump inhibitor, or this can increase the source of infection because it decreases the acidity of the gut, which can kill some organism. So this one related to the maternal and the baby's issue. Of course, if he is a preterm, he doesn't got any immunoglobulin from the mother and his immune system is unwell. How can this neonate got the infection? Again, just I am trying to present it by many ways so you can understood how is the infection are the first enemy to us in the NICU. It can go through the transplacental virus more than bacteria. So we have torch, called it now torships. Okay, you must go and read about this congenital sepsis. But it can come also vertical. I mean, it will become from the mother infection. Okay, not through the blood. It came through vertical one, like GBS, Escherichia coli, Listeria, all this. Sometimes it came horizontal from bacterial, from nosocomial, from our side. Klebsiella, staph, MRSA, Pseudomonas, Proteus, Serratia, all these fungi, all this can come from horizontal. So either through the blood, through the placenta, or it come horizontal, vertical from the mother, or horizontal from the healthcare worker. Again, this is how it came through the hematogenous and the many viruses. You need to go through this slide, are very important. Okay, either viral infection or other organism like toxoplasma, listeria, syphilis, TB, like that, and or through the ascending through the maternal genital tract. That is most of the organism which we just discussed. So even the baby inside the abdomen is still in risk, either from the blood from the mother, from the genital tract, or the mother has colonized or infection, and he is very also weak. And sometimes the infection is the cause behind the preterm delivery. So the neonatal sepsis, its common manifestation is non-specific, but it can come, I mean, the general symptoms can come by meningitis, pneumonia, bacteremia, UTI, osteomyelitis. Many cases you awake and find that the baby is not moving one limb or his limb is swollen, and when you did the X-ray, you will find osteomyelitis, maybe congenital, okay? Congenital infection, we speak about that. It can cause a rash, hepatomegaly, infection of the eye and the ear. Can affect, of course, cardiovascular system with myocardial affection and the hypotension. Sometimes it is presented as IUGR. So all this neonatal infection, okay, infection of the newborn, especially bacterial. And you see, I just bring this blood vessel outside to tell you if you did any central line or even peripheral line without cleaning, it will be, you will put the organism directly to the center. Another clinical presentation is the necrotizing enterocolitis. You can see this abdomen, which is very distended, red, shiny, okay, and you can see the child even changed color. So all this is NEC, necrotizing enterocolitis, which is one of the criteria of severe sepsis. Okay, so clinical signs and the symptoms of sepsis are non-specific, and the differential diagnosis is board as RDS, TTN, metabolic, cardiac, CNS, and inborn errors. All this mimic the sepsis. That's why you need to rule all that. There is common non-specific but common, like temperature irregularity. Usually, neonate, if got infection, they will get hypothermia. Rare for full term, sometimes they can get hyperthermia, but usually most of them will be presented by decreased temperature. So if you find the temperature low, take it serious also. A change in the behavior, the best one is the mother or the sister, which will guide you that my baby looks lethargic today. He's not moving as before. He is irritable. He has changed his tone. He looks more relaxed. He didn't want to feed. He's sleeping more. His skin looks mottled. All this denote poor perfusion of the skin. Sometimes he has mottling or cyanosis or pallor or peachy or rash or jaundice. Even jaundice sometimes accompanied by infection. He has feeding problem, feeding intolerance, vomiting, diarrhea, abdominal distension, ileus. All this, if it happens, it is non-specific, but very, very important and dangerous clue. If you didn't pick it, the baby doesn't need a lot of time to be collapsed. So take care, please. If we suspect, we must collect the blood sample for investigation and give the antibiotic as soon as we can, preferred not more than 1 hour. We'll speak about that. Of course, the cardiovascular system, okay, like tachypnea and respiratory distress, tachycardia, hypotension, bradycardia, pallor, mottling, sclerotic skin Skin sclerosis are very important. If you catch the skin, it is not elastic like the normal one. It will looks like wood, as if you are catching wood. This is known as a sclerotic skin, which is a very late sign of sepsis. Gastrointestinal tract, of course, can come with vomiting or abdominal distension or hepatomegaly. Metabolic, you will find the dextrose are not adjusted, usually high, but sometimes it can come with hypoglycemia or metabolic acidosis. If you started to decrease urine pass by oliguria, okay, all this thrombocytopenia BTK is an important clue for the sepsis. Another less common symptom, but very serious. If you left the baby, you didn't diagnose him early until he started to convulse or to bleed from the IC. If you got BTK, if you got hepatosplenomegaly, it means the infection are very, very, very severe in the blood. Jaundice, severe jaundice, meningitis, okay? Hypotonia, hyperreflexia, full fontanelle, all this denote a very late, we don't know how is the response will be. So please treat the infection early. Don't treat it late, because even if you treat it late, sometimes you got baby who has a lot of morbidities. So this, you must be honest. And if you used it to say, if you are not able to smell the infection, you cannot work with neonates. You must be able to suspect it and take it serious. No issue to start the antibiotic and stop it after 36 hours or after 48 hours, after make sure that everything is okay. Better than leave him for this 36 hours and find him after that in a very bad situation. Again and again, how is the manifestation of the congenital infection, which is different from the postnatal infection and from the perinatal infection. Every one of this has its own manifestation. If it is congenital, you can find IUGR, congenital malformation, fetal loss. If perinatal, you will find the baby with septicemia, meningitis, pneumonia, preterm labor. But the postnatal directly is meningitis, septicemia. Sometimes the conjunctivitis are very important, okay? And every area, okay, will give its own effect. Like if affected the eye, you must think about Neisseria, gonorrhea. Chlamydia will affect the chest infection, the same like mycoplasma in school children. All this one can affect person to person effect, and even through the umbilical or staph and the tetanus. So you must go through all this, please. How to diagnose? The gold standard is the blood culture. But how much is it positive? It is positive less than 50%. Okay, why? Usually the mother are given antibiotic, even single dose. It will affect the culture. And also the blood volume. We maximally can suck for the blood culture 1 ml. Some said it need, and some only send 0.5. Blood CSF and urine culture can be needed also if we suspect it is meningitis or pyelonephritis. Chest X-ray are very important to diagnose the respiratory symptom. It made the child progress for RDS. Disseminated herpes are very important to good culture from the conjunctiva, the mouth, the anus. Maternal exposure history are very important. So diagnostic method, as I told you before, we are dividing it into 4 pillars. The lab, the gold standard here besides the other inflammatory marker is the blood culture. The red, sometimes you need chest X-ray, you need to do brain ultrasound to rule out any IVH or ventriculomegaly. Okay, so we have lab, we have red, we have a bedside tests like blood gas will guide us, blood sugar will help us. So this is very important, please. Of course, the culture, either aerobic or anaerobic, are very important. Usually the organism will appear within 48 hours. Okay, so we will start by the first line, but guided by the culture, we are going to change. Enough to go single site blood culture, not like in adults, we may need to take many culture. During culture also, if needed, it must be under complete sterile, like suprapubic or transcatheter. You must be able to comment about the CBC, okay? But CBC usually need to be serial, because you, in the first one, it may be okay, you repeat it, second day you will find thrombocytopenia, neutropenia, like that. So serial detecting of the blood changes are very important. The C-reactive protein is an acute phase protein associated with tissue injury. It is elevated at some point up to 90% of the infant with systemic bacterial infection. But the most important is not CRP alone, is the level of rise secondary to macrophage, T cells, and adipose producing interleukin 6. This especially true infection with an abscess or cellulitis of the deep tissue. Remember that procalcitonin now and the other marker are available, and it has its benefit or advantages. So the CRP level is not recommended as a sole indication of neonatal sepsis, but may be used as a part of a septic workup and as a serial study during the infection to assess the response to the antibiotic, determine the duration of the therapy, or identify a relapse of the infection. Clinical sepsis with only positive CRP needs a short course of antibiotics. Again, the clinical sepsis with only positive CRP, it will need only short course of antibiotic, maybe 3 to 5 days. Other acute phase reactant like procalcitonin and the serum amyloid. Okay, procalcitonin, you must read about it because it is a very good test. Okay, because it is more specific. Okay, and more sensitive than CRP, and also its benefit, it will help you to stop the antibiotic if it is normalized. Coagulation profile, which is BT, ABTT, fibrinogen, fibrinogen degradation product, or D-dimer, all these are very important if you feel the baby are so sick or have severe sepsis. You must do that to treat the abnormal coagulation. Immunoglobulin M concentration in the serum may helpful to determining the presence of intrauterine infection, especially the infection has been present for some time, I mean stay for a longer time. As you know, IgM is indicator of current infection, IgG indication of previous infection. Sorry, just a while. مشتاق اشوفك والله، بس انا اسفا يعني انت مسافر امتى؟ مسافر امتى بالسلامه؟ You hear me now? I think my camera is in wrong situation.
Your camera is back good.
How can I change it to be?
Are you using tablet, Prof?
Sorry?
Are you using tablet or phone?
Yeah, my tablet, my laptop or laptop.
I think it is the rear camera.
Is the rear camera? You can look at the top left, or is it top left?
Choose video filter, video setting, microphone, Microsoft camera, select a camera to switch.
There's a camera icon.
Camera icon?
Yes, camera icon, and then there's an arrow pointing.
Camera front. Maybe like that.
Yeah.
Yes, now you can see me. Most of the time you are getting some candy. so sorry for that. Let us come back to share the screen. Can you see now?
Yes.
Okay, so I will make it full screen. So coagulation profile are very important, especially if we know that many kids can progress to DIC, disseminated intravascular coagulation, which has a very bad mortality and morbidity unless you are managed it very rapidly. Okay. Of course, lumbar puncture are very important indicator of the infection already reached to the CSF, especially for increasing white count, protein, decrease glucose. Of course, the top one is the positive culture. Sometimes we need to do PCR for the herpes simplex because herpes simplex, if it came, its mortality are very high, and then one who can escape the mortality also, we have very high morbidity. Okay, this is a very important point. Radiology, as we speak, chest X-ray, CT scanning, and MRI can be needed if we suspect a lot of changes or complication. Okay, ventricular dilatation, encephalomyelitis. Sometimes you need to do CT to diagnose osteomyelitis. We have one child with osteomyelitis in the upper humerus and the clavicle. Until we did the MRI, we was not able to see is it fracture, is it trauma, is it like that. So it is very important. Of course, the head ultrasound is in our hand. It can guide us to rule out some evidence of meningitis. If we diagnose sepsis, how can we diagnose? Okay, the best thing is the prevention. That's why to work together with our staff in OMG are very important. So maternal antenatal care, swab for GBS, universal screening for all pregnant women from 35 to 37 weeks are indicated in many countries. Okay, early recognition of chorioamnionitis and starting antimicrobial, intrapartum prophylaxis with penicillin, ampicillin, cefazolin 4 hours before delivery are very important. Because if you start early, it can protect the baby. The second thing is to decrease hospital-acquired late onset sepsis by washing hands for infection control. And sorry for that, I really may blame someone if he think if he's going to pray for Allah, he will wash his hand as a part of wudu, and he didn't wash his hand to prevent the harm for other people. So just said this is the same. We are obeying the order of Allah. We are washing our hand Okay, but we need also to wash our heart and wash our hand to protect the patient in front of us, especially if he's immune compromised, like very low birth weight or any patient who is immune compromised. Okay, central line are very important. So every central line you must write when inserted, what is the time to remove or change like that. Okay, of course, the hand hygiene is the top important. Some are speaking that intravenous immunoglobulin IVIG, they said it is not. Anti-staph monoclonal antibody, some said no effect, but there is one, baggy Paximab, may have some effect. Okay, CSF, GM CSF, they said no efficacy in neonatal sepsis. Okay, so there is a lot of things. Probiotic also not proving sepsis, usually as a prevention of necrotizing enterocolitis only. So there is a lot of things. Sometimes the doctors try to practice it because the baby in front of them is deteriorating. So sometimes they are try in our area before. Sometimes we did exchange transfusion. We are changing the blood of the baby. We need to decrease the load of microbe in the blood. So we are trying everything, but usually the results are so bad if you didn't start early. Remember that there is another manifestation like jaundice, which will occur about 35% of the sepsis. So if you got the baby jaundice in the first 24 hours, we are calling it pathological jaundice. If you cannot say is it pathological to blood group incompatibility, RH or ABO or other thing, you must consider him as sepsis until proven otherwise. Of course, hepatomegaly, poor feeding, vomiting, all this is complementary. Okay. Fluconazole are very important. It is effective in prevention candida sepsis in very low birth weight. Okay, but the neurodevelopmental outcome is not completely addressed. Is it able to give us resistant strains? Can be, but usually it is working nicely if you are giving antibiotics. So please use it besides the antibiotic to prevent super added fungal infection. As I told you, you must be able to smell the sepsis. If suspected neonatal sepsis, treat. And treatment should be initially immediately started after rapid sampling collection for aseptic profile. Start with antibiotic as soon as possible. Do stabilization of the cardiopulmonary monitoring, cardiopulmonary support, intravenous nutrition. No need to give him feeding and then he got NEC. Blood product transfusion as RBC or FFP or platelet if required, and the temperature support and the glucose also. So this is a very important line. Judicious use of antibiotics are very important. Okay. Don't give antibiotic without many things. If you are going to start antibiotic, you must ask yourself for how long. Don't forget and leave it for longer time. Okay, like the same if you are going to intubate baby. So I am intubating him maybe for a short while until his respiratory distress resolves. I need to intubate him for a bit longer time because I am going to do operation and stay. So you must be clear. We have many lines. The first line in ICU is C-Ben Genta or ampicillin Genta. This is the first line. And after that, we can go either cephalosporin or vancomycin if suspected. So we have usually piperacillin, tazobactam, may consider as the second line. Piperacillin, tazobactam with amikacin. Of course, ampho or fluconazole can be introduced if as a prophylactic or as a treatment. There is newer antifungal which are more effective. The antibiotic now, we are going to start by empirical antibiotic, usually Cibin and Digenta, okay, until the culture came. If the culture came positive, you must go through, switch your antibiotic based on the susceptibility in the culture, okay? And you must define the duration of the antibiotic. How to define the duration? Let us give an example. Early onset sepsis without meningitis, it may be enough 10 days. Late onset sepsis without meningitis, also from 10 to 14 days. Meningitis for early or late onset, at least it is from 2 to 3 weeks. Gram-negative organism, especially accompanied by meningitis, at least 21 days. If you have osteomyelitis, it will be for 6 weeks to 2 months. So the course must be clear for you. Like TB, it may be 6 months to 1 year. So it is very important. This is the healthcare associated infection or nosocomial infection. It is 100 common than congenital infection. Okay, NICO is the highest rate. At least 12% has one or more infection. Many pathogens are developed known as drug-resistant microorganism. Before I finish, I just let you revise your pediatric protocol, and I always tell you and tell your colleagues before, if we have our pediatric protocols in Malaysia, this is a very, very important because it is touching not the general medicine, but it touching the practice in Malaysia. So please, you must come back for it. It is very nice book. Don't read from the old edition, please. Go for the latest edition. It is full of knowledge and full of wisdom about how to deal with the most common problem in our unit. And if you have your own protocol, it is very precious thing. We speak about congenital syphilis in the book and its transmission rate, which is up to 90%, and it usually can be asymptomatic, but it can be presented by hepatomegaly, skeletal, otitis media, bursitis, lymphadenitis, a lot of. How can we diagnose also by RRR or VIDRAL are very important. How to management it is from 10 to 14 days of aqueous penicillin. Okay. So now, who can answer now? Should I choose or someone? Let me choose and give you a chance, unless someone can comment in this one to the top to the left. Who can comment?
The first picture, it seems like the patient or the neonates is having oral candidiasis.
Yes, good. So it's known as thrush stomatitis.
Oral thrush.
Yes, thrush stomatitis. You can find the white coat, but the most important, what is this white dots? This is the satellite around it. It is very diagnostic also. All of this, sometimes if after feeding, the baby looks like that from the milk. So sometimes you need to make sure it is not a milk curd to diagnose it. And it needed to be treated, okay, for at least 7 days of oral antifungal. And sometimes if the mother need to sterile her nipple also. So what is the one top right? What is this?
The umbilicus.
Yes. What happened for the umbilicus?
I can see that there is a discharge coming up from the umbilicus, and the redness surrounding.
Yeah, very important. Periumbilical erythema is a very, very, very dangerous. Why? What was here, which we cut when we cut the umbilicus? There is UVC and UAC, which is a vein going directly to the central artery. One go for aorta and the other go for the inferior vena cava. If the infection appears here, it is very dangerous. So you must admit the child, even he is 100% looks normal. Because if you lift him and this periumbilical erythema or infection came to make onpholitis, so the baby will be infected and deteriorate very rapidly. So we need to admit it and start for him oxacillin for at least 5 days. Am I clear? So this one fungal must be treated with periumbilical. Sometimes even it happens in the toes of the child, you will find the erythema. You must admit and treat because staff feel that they are very strong against babies. What about this one? Right lower. Just I need someone to prescribe.
Necrotizing.
No, it is
Oh,
not.
no.
What is there in the
But-
skin? What is there?
Rashes.
Rashes and pustule.
Pustule, yes, this is very important. So if you see this one and you ruled out a most common cause, which is erythema eosinophilic, erythema of the baby. If you suspect it is herpes simplex, you must start directly intravenous acyclovir. This is a typical vesicle of herpes simplex. Okay? If you leave it, it is still in the skin. If you leave it for a short time, it will go directly to the brain. And if it came to the brain, very bad. So please, if you find the mother, that's why if the mother has any herpes simplex in her genital tract, we are not giving a trial for vaginal delivery anyway. We must do cesarean before the uterus open. Am I clear? Because catching herpes simplex are very dangerous. Of course, this the other baby, it gives you an idea what is going with the babies. I mean, how much care the baby needs. He needs to be intubated and put OGT tube. He needs to insert central line through the umbilicus, one through the UVC and one through the UEC, which is a very good central line. We need to for monitoring, we need for pulse oximeter, we need for ECG lead, we need for sedation, we need for antibiotics. So the baby have a lot of service in spite he is a very young. With some references, but the home message is please try to be careful in taking a history and the meticulous physical examination along with appropriate investigation are the essential for the diagnosis if any neonate has sign of symptoms of sepsis. Guided by the history, if a preterm, okay, we know that he is susceptible. If the maternal has history of chorioamnionitis or fever or GBS or UTI or this early onset sepsis. Early suspicion and the monitoring and the intervention. So you must be very obsessive about sepsis. You must monitoring the child, you must intervene, and accurate management can prevent a lot of complication, mainly the septic shock. Of course, the top importance is prevent the healthcare associated infection. We must be very honest, and we have some form known as clepsy, which is the central line sterility. Okay, it is very important. If you have time, we can just speak about one example of early onset and one for late onset and one for sepsis infection. Just remembering you that your exam is near, but also Ramadan is coming soon. enough until here, and let us give some examples. Okay. Who can raise his hand to ask questions? Just simple scenarios. No one? Okay, I have a big list in front of me. So I don't know who is MS. Suhaila Pauzi. Suhaila?
Yes, Prof. Yes, Doctor.
Are you ready? I will give you a simple scenario. Okay. Now you get a phone from ONG that there is a mother who came on delivery. She came around 8 centimeters. Okay. So they just able to give her one dose of antibiotic, short time, it may be less than 2 hours. When the doctor goes through her previous logbook, she found here has GPS on 35 weeker. So what is your decision now?
Give prospector antibiotic
Why?
because of the GBS infection.
Early neonatal sepsis. So number one, when you are asked any question, you must go through the normal pathway. The normal pathway is the history. So you must need to ask any other history of the mother. And the mother has a fever, has leukocytosis, has CRP high, has UTI. All this, it will support the diagnosis. So always when you come to any scenario, you must know that this is like a ladder. The first step is history. The second one is the clinical examination. The third one is the investigation. So you must ask about the history of the mother. I will tell you, yes, the mother has fever, 30.5. We suspect first it is due to delivery, in spite it is high. But when we send also the investigation, we find here leukocytosis and the neutrophilia and the CRP is high. So now I came to the diagnosis of chorioamnionitis. If I didn't start early, within a short time, the baby will deteriorate. So that is the importance to diagnose the early onset sepsis. Am I clear?
Yes.
Okay, so now if you asked Nadira, because I left Nadira up in the ICU to contact me if there is a patient. Yes, Nadira Azhari.
Yes, Doctor.
Yeah, now hopefully delivered in the unit 25 weeker who is 800 gram, and we are able to intubate him and give him surfactant and extubated, and we finish a course of antibiotic on his day 14. The sister, which is very near to him, at the time still the weight is less than 1 kilo also, but the baby already on just nasal bronch and near full feeder. The sister asks you, this 14 days old baby looks behaving abnormal. He's very lazy. He refused to feed. And when she feed him, he started to vomit. And really during this, his morning blood gas, we can find that the dextrose is slightly high. and there is some sort of mild metabolic acidosis. So what did you suspect it can be?
Late neonatal sepsis. Late onset neonatal sepsis.
So it is very important to consider, especially if the baby doesn't feed or vomiting or all that. So we must continue. Usually for the early one, we are starting by the Sibengenta. For the late onset, sometimes you are going for the piperacillin, tazobactam, and the amikacin, okay? Which are very, very important. Am I clear?
Yes.
Also, if you found the mother also have any history, nor is the, okay, do you have very limited pool of names, okay? Nor is the, yeah. If you, after delivery, you got a baby who is very, very small for gestational age and or IUGR, and you found him has cataract. As you know, for every neonate, we must do red reflex. Red reflex, we are bringing the ophthalmoscope around 30 centimeter away from the eye, from the lateral side, and see if the red reflex is red, so it is normal. If it is not, if it is white, so it is very dangerous. It can be either cataract or glaucoma or retinoblastoma. And you find the red reflex is white one. And when you examine, you find his spleen is large. Hepatosplenomegaly, sorry. And there is some skin rash. What did you suspect? Again, IUGR, the red reflex is white. There is hepatosplenomegaly and there is a skin rash.
Can be congenital tortious infection.
Yes, but tortious, every letter is a different disease. So what system else do you need to examine? It's very important for the heart. Okay? Because every one of the torch has its own criteria. I mean, if I'm speaking about rubella, congenital rubella, so you will find in the eye, there is cataract. In the ear, it is affected. In the heart, it is affected, IUGR. If you come to cytomegalovirus, you will find the different. Toxoplasma is different. So you must go through your reference and see
Marilah kita bersama-sama menaikkan solat di awal waktu kerana Nabi Muhammad SAW pernah ditanya, apakah amalan yang paling terbaik? Lalu baginda menjawab, solat di awal waktunya. Untuk maklumat, solat fardu boleh dilaksanakan mengikut jumlah jemaah dan SOP yang telah ditetapkan. Adalah dimaklumkan bahawa tiada pegawai digunakan untuk melawat sakit pada ketika ini. Hanya seorang penjaga digunakan untuk menjaga pesakit di ward pada satu masa. Sekian, terima kasih.
So it is very important to go and read simple table about the difference between different type of congenital anomaly. It is very simple, it will guide you, okay? But as a rule, you will find the baby is IUGR, his eye may be affected, his ear may be affected, has respiratory stress maybe, but has congenital heart disease, has skin rash, has splenomegaly. So you must be able to say which part of torch, which known as now tortious, because it is extended diseases. Okay, I hope you can pick the point which I need to tell you about the importance of neonatal sepsis, and you must be able to smell the sepsis before it became fulminant. I mean, pick it from the early stages. which gives the best result of the baby. The most important is washing our hands, prevent healthcare associated infection, which is the most dangerous, which is more 100 common than the congenital infection. Please take care about cleaning your hand, and remember always in Islam, لا ضرر ولا ضرار. You are not allowed to cause harm. Your job is to give benefit. Sometimes you are not able to give someone the benefit. Sorry, we don't have treatment for that case. We are doing like palliative treatment. Yes, we don't have treatment. We are not the God. We cannot judge everything. So you must be honest. Don't cause harm. Don't cause harm. Starting from the healthcare associated infection. Now it's your turn if you need to speak or ask any questions. Did you swallow the lecture?
Yes, doctor.
Do you have it or should I send it to you? If you don't have, let your colleague contact me and I will send it to her. Now let us open our video together. Who can put us in one view? I'm not so. Can be? Hazim, can you put us in one screen?
I'm not sure how to put.
Who can help Hazim?
Choose gallery. Change view gallery. For the view, choose gallery. So who's going to take the picture?
Of course, you.
Actually, my laptop. I'm not sure how to capture the screen.
I can take it.
Hidup Zakwan.
So Muhammad Noor.
Yeah.
Zakwan.
Only but half of us do not open camera. It's okay.
Who can help him? In the last meeting with new batch, they are able to do it. It may be I need to minimize me and Hazim.
Sometimes due to the internet, the video didn't come up.
Cannot.
Sometimes due to the internet. Those who have a strong internet connection, who can view all the.
You can get two or three photo and you can join it together. No issue. So new job for me to prevent neonatal sepsis. Okay.
Zakwan boleh tak?
Separuh tak ada. Try E.
Sama, aku ada 4 orang je yang ada kamera. Only 4 people I can see.
Saya pun ada 4 orang je. Saya ada 4 visual.
Siapa yang guna internet sendiri, who use their own internet can try.
Anyone can view the whole classes, the whole class members. or at least more than 4 or more than 5.
I did it for you. Okay, I think this is 5 by 5. We are 25. City Adawiya, the only one who is not available now. Are you around the city? Adawiya?
Yes, doctor. But my camera is not working.
No issue. خلاص, go to one photo now, Hazim. We make it simple for you. So at least I know your faces. If I need to revise anything, I can know. Okay. Who will do it? Ladies must intervene and help us.
I'm sorry, but I'm also cannot see the whole or of the.
Okay, the whole is
other
with me. Got it and send it to you. Okay, Bismillah. Here. Yeah, this is a good idea, really, to know ourselves. All smile, please. Smile. Okay. One more to choose between it. Okay. Thank you. Do you need to ask me any questions before Al-Asr?
No, doctor.
Okay.
No,
For tomorrow, we have RMS symposium tomorrow. Even some of your colleagues in fourth year, they are able to attend and present some paper in it. I don't know if someone invite you before or not. It is only, I don't know if it's still opened. It is only 50 ringgit for the symposium. It will guide you for the issue of publication and the researches. It will be tomorrow morning. So I think our NRB, we can do it a bit late. What did you prefer? After Maghrib or after Isha? Is it valid for you or difficult?
after Isha.
After Maghrib or after Isha, as you wish. Either we said it will be 7:30 or 8:30. It will
I
take.
think after Isha is okay, doctor.
Sorry?
After Isha is okay.
After Isha is okay. Okay. Inshallah, 8:30, 8:40, inshallah, we can start. And I will send you the lecture of today and tomorrow, inshallah, to go through it. Okay? Nice to meet you. Assalamu alaikum wa rahmatullah.
Thank you, doctor.
Assalam. Thank you, doctor.
Thank you, doctor.
Assalamu alaikum.